the stabilization. So we will do this kind of, you'll see we go back and forth naturally. I'll speak in English, of course, but I think I can, over many years, speak in a slow and use nice words so it's understandable. But some things we like to have more detail in Italian, so then we can do that. Yeah. The other thing is, we're a small group, it's a small room. If you have a question, we can just jump in. Just like, hey, what about this? What about that? That's fine. So we'll try, we really have, do we have still 2 hours? So we still have 2 hours. So that goes till 4:15, something like that. Maybe a little less. I'll try to get through the presentation in an hour. So there's a lot to talk about. You can tell I'm already like, my voice is not happy. And then we'll have a real practical experience of demonstrating the stabilization of the child. But one thing I don't do, and I've never done, is the care of the child in what we say in the field, by the road, by the side of the road. But Davide does it a lot, right? Yeah. And I guess in Italy, the doctor goes out into the field. In the US, the doctor never goes out of the hospital. The ambulance goes by themselves. Literally, the doctor never goes. Sometimes the doctor goes when you transport from one hospital to another, but we never go to the scene of the accident. So, okay, anyway, so we'll just get started. We're gonna plug in something here. Oh, nice. Okay, thank you. Okay, now I've got this, so I have the complete control of everything. All right, so, children are not little adults. Everyone hears and understands this. A child is very different. But let's take a few slides to really go into some detail about how exactly is the child different than the adult. So there are certain things, and there are many differences, of course, between children and adults. But these are a few that are important for the trauma patient. So probably the most important is the relative size of the head to the body. Remember, the infant has a big head, and then as we grow, our body grows, but the head doesn't get as big. So what that means is, in the same accident, in the same trauma, more often a child will have a head injury. Their neck also is not as developed. So, you hold a baby and his head is like this. So if there's an accident, the head is more likely to be injured. Another thing is the skull is not hard, right? Like my skull is hard. The baby's bones are still expanding as the brain grows, and the baby has the fontanelle. So there's more chance for injury to the brain. But it also provides an opportunity, if the brain has swelling, the pressure doesn't necessarily go up as fast because the bones can expand. And also because for ultrasound, because in Italy, I think the echo fast, you call the echo ultrasound, is very common. You can just, look at the fontanelle. You can't do any ultrasound on my head. So it's a nice thing for the baby. Shorter trachea, the whole airway is very different. The trachea is shorter, right? It's not as long. The larynx is shorter. It's not as long. Also, the trachea is shorter. Everything is shorter. And the shape of the larynx is different. So it's not like a cylinder or a tunnel. It's more like a cone. When you're looking at the baby, it gets smaller and smaller till you get down to the vocal cords. And of course, below the vocal cords is even more narrow. So in the baby, the subglottic space, the area underneath the cords, is smaller than the cords. Whereas for the adult, the smallest part is the cords. So these are important when you manage the airway. It's harder to intubate babies and small children. Just the look, you're looking through a small mouth and you've got a tube, and the tongue is kind of big compared to the mouth. So this is the challenge for us as pediatricians. We just have to, there are some things that are harder for us to do than for adults. Smaller airways mean higher risk of obstruction. So if I have an injury to my neck and maybe a 1 centimeter, deviation into my larynx from a trauma, I can still breathe around that. But the same injury to a baby, complete obstruction, can't breathe. So the whole airway is more sensitive. Do you have something else to say about this? Yeah, the trachea is very mobile. It moves around a lot in the baby, this part. So, one consideration, if you have a tension pneumothorax, you remember this, the trachea can move over because there's so much pressure, it moves over. But one thing I would say for a practical consideration for the airway, when you're attempting to even use bag mask ventilation, or certainly when you're going to put in a breathing tube, you want to make the baby, the smaller, more important, make the baby very straight, nice and straight like that. So when you look here, the cords are right here and the trachea is here. If you're moving, if it's turned at all, especially a baby, if you have a baby like this, the cords are way over to the side. The vocal cords are, and the trachea. So yeah, one little trick that I like to do, not with a patient with cervical spine injury, but another baby, if I'm going to intubate, when I get everything set up, the last thing before I do this is I gently take the head and I just slightly pull to straighten the baby out. So the shoulders are straight, the cords are straight. So all of these are important. These structures are mobile and they're small. So that's a very important point. The chest wall is more compliant. That has some implications for respiratory failure. Remember, the babies don't have a rigid thorax. They don't have bones that are fully calcified. So they can more easily have respiratory failure. And especially with trauma, if I get a trauma to my chest, since my chest is rigid, I can still breathe with that. But a baby can have more collapse. So that's a problem. And then finally, yeah, do you have something on that? Yeah. Yeah. And then finally, the abdominal organs also are much more exposed because the baby's abdomen is relatively big compared to the chest. And this is not this is like a cage that protects my liver. My liver's up here, but the baby's liver is more lower. The baby is, especially the spleen. The spleen is really, if you try to find the spleen on an adult, it's really hard to find. But a child can have kind of a big spleen. And so you'll see splenic injuries to the spleen, much, much more common in children than adults. No, it's important. Okay, what about physiology? So there are many also physiologic differences between adults and children. Babies, or I keep saying babies, but especially babies, but toddlers and young children, the younger you are, the higher your metabolic rate is, your resting metabolic rate. So you can develop shock more quickly than an adult because babies are needing more delivery of oxygen. And so, so that's another thing we just have to deal with. they need more oxygen in their tissues relative to the output of their heart. And there's many things that, that affect the baby that way. So cardiac output, for example. Remember, cardiac output is the product of the heart rate, like how fast is it beating, and the stroke volume. So how much blood comes out and how fast does it beat? So a nice example is if we're adults, we're sitting here, maybe I'm relaxed, my heart rate is 60 right now. And if I have hemorrhage, I can immediately take my heart rate to 120 and I will double my cardiac output just with rate. And if I'm still pretty young and healthy and I don't have coronary artery disease, I can maybe triple my rate. I can go up to 180. But a baby whose heart rate is 140, he can't double it. He can't go to 280, right? So the baby is limited, is heart rate limited. The baby is also stroke volume limited. I can double my stroke volume just by having more filling of my heart. I have more contractility ability in my heart. So the squeeze of the heart. So all of the mechanisms for cardiac output are more developed in adults. So what does that mean? That means here's where I am, and this end of this line is I'm in shock. I've got a lot I can do. I can double my heart rate. I can increase my contractility, etc. Oh yeah, this is a good one too. Oh yeah. You want to show that to them? Or? Yeah, it's a good one. Take a look at it. Oh yeah, it's a good one. The baby lives a lot closer to shock at all times. That's the point. The baby is always closer to shock. And remember, if you define shock where the demand for oxygen is greater than the supply of oxygen. So the baby is always closer to that. And so that's why you can see these sudden crashes where the baby looks fine, the child looks fine, and then suddenly, boom, not fine. Yeah. So that's why this is general advice as a pediatrician. The best thing you can do is frequent re-examination of the patient. The child is not going to give you a warning. They look okay, they're okay, boom, they're not okay. So frequent re-examination, just quick, still good. Checking, is the mental status still good? Checking the refill, the difference between 2 seconds and 3 seconds is important. 3 seconds to 4 seconds, big warning sign, right? So, and of course, children don't talk to us. If I'm in the emergency department, I can say, "Oh, David, I don't feel good. Something's wrong with me." Children say nothing, and then they're in trouble. So this is good advice. I did this demonstration last time and I think it's good. This is a concept of circulating blood volume. So remember, for infants, it's about 80 milliliters per kilogram. You can find these references. For older children, it's 70, and maybe for school age children, 60 milliliters per kilogram up into adults. So adult male has 5 liters of blood volume. So I have 5 liters. If I lose 10% of my blood in a trauma, that's going to be shock for me. If I lose 20%, it's real shock, deep shock. So 20% would be a whole liter of blood. 10% would be a half liter. So if I lose, this is a half liter, if I lose all of this blood, I have shock. But think about the baby, think about the toddler, right? Who is 10 kilograms, 1 year old. 10% of his blood volume is 100 milliliters. So that's just this much. So if the baby, here's 1, 2, 3, it's even less. 1, 2, 3, 4, 5. 100 milliliters is only this much. If a toddler loses that much blood, he's in the same kind of shock as if I lose half a liter. And sometimes people don't appreciate that, especially adult medicine specialists. You can lose even from a scalp hemorrhage 100 milliliters. Yeah. So hemorrhage control is even more important in smaller. Quick, effective hemorrhage control is very critical. And we could take an extreme case, the infant who's in the car accident weighs 3 kilograms. Their circulating volume is 80 milliliters per kilogram. So their whole blood volume is 250 milliliters. So if they lose 25 milliliters, I mean, that's nothing. They're in shock. So a baby who's bleeding, that's an emergency. Like if he's in the emergency department and he gets this little infant in the car seat and there's significant blood on the clothing, just assume the baby is in shock, probably. So these are important differences for physiology. Last, I would mention some of the issues with respiratory rate are similar to cardiac output. Babies have a higher resting respiratory rate than we do. So they have quicker respiratory failure. Remember, they don't have babies are mostly breathing with their diaphragm. They don't have all this chest wall muscle. So they're at higher risk for mechanical respiratory failure if they have any problem with their chest. Again, if you punch and break my ribs, I'm probably okay. And even if I get a pneumothorax over here, not tension, but if I get a regular pneumothorax, I can still come into the emergency department still talking. And if you check my pulse oximeter, it's probably okay. It's not that way with the baby. they're just important points. As pediatricians, you are the expert in children. You need to know and understand these differences because you will talk to other doctors who don't know pediatrics and they won't realize what they don't know. You see what I say? They won't know what they don't know. So they'll say, oh, I have a baby. He had some bleeding, but I think he's okay. Oh, really? I have a baby with a chest injury, probably okay. We have to be more careful with children. Okay, so how we do the assessment is similar to PALS, but a little bit different. We do start with the with this PAT. You're familiar with Pediatric Assessment Triangle. That's the quick looking, and basically you're walking to the patient and you're trying to decide, are they sick or not sick? Are they critical or do I have time? And you're mostly looking really for things such as their appearance. Obviously, are they unconscious? Are they anxious? Will they not stop crying? And looking at how they're breathing. Is it difficult or easy? And then finally looking at the appearance of their skin. And I'll show you a slide on that. Then we go through these A, B, C, D, E, airway, breathing, circulation, disability, which means looking for like a neurologic problem. And then exposure means expose the body. All the clothes come off. We look top to bottom, head to foot. So probably the most important part of a trauma evaluation is that we stick to this principle from the beginning to the end.
Non mi vado a sistemare quello che sono i teaser principali. Tengo lo fatto e in tre tra tre lo soggetto quelli che uccidono quelli che uccidono primo uccidono A il secondo killer del fuoco.
Yeah, absolutely. So if A is not good, all the rest is bad. So you have to get A, you have to make sure A is good first, airway. If airway is bad, we can't go to breathing. And probably, but you have an expertise in ATLS. This ATLS is advanced trauma life support. And you say also PHBLS. Yeah, TLS. Yeah. Yeah. So that's where, I mean, these things happen fast and they happen. I mean, A is first, then B, but bleeding has to be stopped. Because if I'm bleeding out of my femoral artery, I might be dead before I can do the A. So someone has to get the bleeding stopped. And then we're doing A, B, C, D, E. Yep, exactly. And we talked about it last time, but we don't cut the corner. It's an English, it's an expression we have in English. When you cut the corner, it kind of means cheating a little bit, not doing the right thing. Like I say here, here's when I'm taking and I'm turning the corner. This is the right way. And when I'm cutting the corner, I'm kind of just coming through here like this. See, I'm cutting off the corner. Do you know that expression in English? Yeah. If you didn't, now you know it. So don't cut the corner. Don't cut corners. Don't cut corners, especially in trauma evaluation. It's never going to be good. And when we say, did you really touch every part of the body? The answer has to be yes. Yeah. Yeah, B. You want to, yeah, go ahead, please. A, B. Yep. This is good. Watch this. Yep. Okay. I think I'm looking in the mouth. I don't see any teeth. There's no blood, and it's the air is moving.
Okay. Eventualmente su pulsazione.
Yeah. A little bit of a jaw thrust.
Non lo
Okay.
faccio questo.
Not that. Remember, you can thrust the jaw, but the neck stays stable. Okay. Good.
Ok. Poi guardate il collo del neck.
Uh-huh.
Ok.
And then I'm looking at the neck. I don't see the trachea. It looks in the middle. And the JVD, the jugular veins are flat. Okay.
No emfisema, no masse pulsanti.
Yep. No emphysema, no subcutaneous emphysema. We call that crepitus. Have you felt, has anyone here felt it before? How many have felt it? Oh, a few. Last time it was only one. Yeah, but so a few have felt it.
Chi è che lo vuole vedere l'emfisema pulsante? Chi è che cucina? La prossima volta devo fare il pollo.
It feels like little, I think it feels like this crunchy, a little bit of crunchiness under the skin. It's not normal. You'll never forget it when you feel it. Okay.
Dopodiché, mano sotto.
Yep, feel back there, palpate. Does it feel off? Does the cervical spine have what we call a step off? That would be a big emergency. If it does, okay, now we can apply some oxygen here for breathing to assist, keeping the head completely immobile. And now we need to protect the cervical spine.
Ok, non lasciate mai la testa, non è obbligatorio mettere il collare se non lo potete mettere proprio si vuole. L'importante è che li mantenete sempre bassi. Ok? Collare come si mette, controllate la misura, controllate se sia giusto e questo qua avete il vantaggio che è stabile.
There we go. It's adjustable.
Si può regolare. Quindi vedete la
So then we can slide this under very carefully. He's watching this. If he sees me making a movement, he can say, stop, stop, stop. He always, whoever's responsible for this gets to stop anything.
Okay.
So if I start, sometimes the nurse comes, hey, let me get the IV. And you just be like, stop, stop. Okay, so he's watching me. I'm very carefully bringing
Stop.
this.
Okay.
Okay, now we keep going. Good. Gently.
No.
Up.
Okay.
He stops me. Okay, get underneath. Okay, and then we bring the Velcro up. Seems pretty good.
Non lascio mai il collo, passo a P. Okay.
Yeah.
P o pass. O.
Oh, oh yeah. Do you do your thing? He does a good. I'm going to watch you.
Okay.
He does. I'm going to observe. So, but here's what he's going to do. It's observation. How is the chest moving? It's so important. Probably more important than anything, especially for pneumothorax. And then we do palpation, feeling, right? Crepitus, etc. Then listening, left and right, apex, base, and posterior. And you're mostly listening for differences. You're not listening for a small thing. You're listening for differences. No breath sounds, breath sounds. Okay, and then maybe this percussion, but please, Davide can show you, and you do this thing with your hand.
Se c'è un po' di stare, se ci sono lezioni, dopodiché ascolto, o passo, o apice, se c'è, yes or no, Se fosse solo dentro alto, fuori eventualmente aiutate e se c'è se il paziente non dovete fare manovre. Conto la mano va messa così e soprattutto perché se ho una visione di parete per quel po' che farà il bambino cercherà di respirare con libertà. Io metto la mano qua, non sentirò mai questo. È importante prendere la frequenza respiratoria e prendere i dati respiratori in 10 secondi di cada non mi interessa sapere se è 28, 29, o 30, no, mi interessa sapere se tardi non di qualità, bravi non di qualità. Perché nei due estremi dobbiamo prendere la mano, portare considerate però che l'importo è che non si aumentare il rischio che succeda un sta pensato in vita. Qualcuno mi dice ma un paziente scioccato un centimetro non legge. Io lo vedo è sensuale. Allo stesso senso di quando faccio il la strada tu hai un paziente vergine e il verso è distante quindi quando compre poi ci lavori sopra e questo bambino va verso il miglioramento culturale. Se va verso il miglioramento si è dopo questa cosa è un peggioramento interno e torno in alto. Peggiorato, quindi faccio perché torno indietro e faccio A, questo B, C. E quando trovo qual è il problema, perché molte volte si chiama errore, siamo dentro una cosa e deve essere quello. E poi non migliore, se non è
Yeah. See, it's very fundamental. It's very fundamental medicine. It's not a time of trauma evaluation is not a time for what I say jazz, like, oh, try this, try that, maybe look at this, maybe look at that. No. Trauma evaluation is a time to follow the recipe, the rules, A, B, C. And when you do that and you're looking for big things, you're the whole idea is you don't want to miss something that's life-threatening. Yep. So now we go, well, we're getting ahead, but now we do C, which is circulation. And then, primarily involves capillary refill. It's so critical. And then palpating the four pulses, extremity, radial, dorsalis pedis, dorsalis pedis.
Quello l'abbiamo toccato perché la prima cosa che proviamo è dei polsi e sentite perché sentite il polso la persona non lo sentite e se c'è anche le ma già sa che se sentite il polso periferico che è capitato e perché è fondamentale? Marc è una cosa fondamentale perché destra, sinistra, perché? Tieni, queste che sono le una posso dire di c'è quando la simetria è fondamentale ed è importante anche perché se c'è una visione della ora, ok? Qua lo sentite, lì no. Okay.
Yeah. So, I mean, it's important that you realize, you can feel the central pulse, femoral, or the carotid, and the peripheral. And at first, when you first start doing this, you'll say, and do it on everybody. That's how you'll get good at it. Every kid you see, every child you see, just try to feel this pulse. And then you'll very quickly learn how to find it. It's nice. And this pulse and this pulse. So if you have no shock, this central pulse is strong, and so is the distal pulse. If you have earlier shock, they're still both strong, but they're fast. If you have later shock, they're fast, and this starts becoming weak. Like, I can't really feel it. Oh, now I can feel it just barely. I can still feel this, but this one is not so good. That is a bad one. This patient is going to have a cardiac arrest soon. If you're only going for central pulses and you can't feel this, that's an emergency. And then after that, you say, okay, I don't feel distal. I can't feel this. The refill is 8 seconds. And now this is feeling decreased. So this is just about arrest. That's the progression. That's the progression. Yeah. So anyway, and again, these concepts actually apply to all resuscitation. It applies to PALS. It applies to a baby that just has diarrhea, no trauma, diarrhea and dehydration. And you say, wow, this is 5 seconds and this is not very strong. Give me 20 milliliters per kilogram. All of a sudden, this becomes 3 seconds. Now I can feel it. 20 more, now 2 seconds. It's beautiful. It's one of the most satisfying things in pediatrics is resuscitating someone with shock and watching their body basically come back to life. Yeah. And you can use this. I mean, sometimes the students at lunch were saying, well, I mean, how can I prepare for the games, the Jockey in September? I mean, the games are great, but I really want you to prepare to be great doctors. I want you to prepare to save somebody's life. So, and of course, the games are great, but let's prepare to save somebody's life. That's the big game. So when you're doing the games, you can say in a simulation, not just, oh, is there pulses? You can say, how strong is the pulse? 2 plus, we say 3 plus, 2 plus, 1 plus. This is a 1 and this is a 2. That's important. Yeah, the difference is great. Okay, and then exposure, this is this idea. We cut off all the clothes. We take all the clothes off. Every part of the body is seen and touched. And, they sort of say something goes in every hole. You look in the nose, you look in the mouth, maybe Foley catheter. You certainly look to see, is there blood at the end of the penis or is there blood in the girl's urethra? I mean, maybe it's a pelvic injury. It's an injury to the bladder. And then behind, how does the anus look? Is there blood there? Is the tone of the anus open? That's obviously spinal cord injury. And I've seen it. And I've seen that the only reason it was discovered was because of that tone of the anus, because the patient is unconscious. They're not moving anything. So I don't know if they're just unconscious or if they have a cord injury. And then you do the exam and you're like, whoa, there's no tone of the anus, for example. So it's not common. It's rare. I've seen it maybe 2 times in 25 years, but I never want to miss it. And you'll be so happy if you catch it. Don't cut the corner, catch it, really roll the patient over, really feel the back. You know, I've seen someone that has a piece of metal stuck into their paraspinous muscle. Yeah. And the patient has hemorrhage, like what's going on? And then you flip, whoa, there's a piece of metal sticking in their back. Yeah. Yeah, anything. So, okay. Now, we've gone ahead. So some of these slides will go more quickly now. I mentioned pediatric assessment triangle. I've already mentioned this. This is coming across the room. You know this from PALS, visual, appearance, work of breathing, etc. So we've already discussed this. Any questions about this? We've already kind of talked about this. Remember though, the PAT happens in about 10 seconds. It's while I'm walking to the patient and I'm just trying to decide emergency or not. And I may not be right. 10, 15 seconds, taking a look. How's the breathing? How's the level of alertness? And what's the color of the skin? It's really done without touching. And this is a good one for trauma. Obvious bleeding. Remember, we have to get control of bleeding. Okay, airway. We've also gone through this, but let's go a little bit deeper now. Anticipate difficult airway management. Remember, I told you there's a lot of different things with pediatrics. Be ready for everything. And have your correct size of your mask. Have a good suction. That's a big one. I mentioned last session. Sometimes in pediatrics, we have this little suction for babies. It's not enough. You want a big suction. We call the Yankauer suction. I don't know if you call it the same thing. Yankauer. It's not just sucking out the nose or anything. It's big. Because really the reason you want it is if someone throws up, and they will throw up a lot, and they always have food. Every trauma patient just had a big meal. It's kind of a joke, but it's true. Everyone has a stomach full of food and everything else. And when that's in their airway, you will just have a second to quickly get them rolled safely and suck that mouth out, or they will draw the food into their lungs. Now we have a big problem. Now we have an airway problem and a breathing problem. So don't do that. Have a good suction. Yeah, just be ready for it. Just be ready for it. It's so great if you're ready for something. It makes everybody relax. So, and like I said, have the correct size equipment. And we're not going to talk about rapid sequence. It's something different you can learn. I think Monica's talking about the airway. It's a type of way to insert a breathing tube where we don't give ventilation. We give the medicine to relax the patient and then quickly put the tube in. But it's not, it's an advanced maneuver. So like I said, these are the assessments. Is the airway open? This is level of consciousness. Do they have any injuries on their face or jaw? That's a big deal. If their jaw is hanging off, it's going to be different to bag them. Are there teeth that are loose? All of this stuff. And then stridor. Stridor's a good one. Remember stridor? Inspiratory sound from the, the glottis. Usually we think of croup. But stridor from trauma is always something that makes me very nervous, because that means there's some injury. Maybe it's a nerve injury, maybe the vocal cord you know, they've had an injury to their thoracic nerve, their laryngeal nerve. Maybe one vocal cord, instead of the vocal cords opening like this, maybe one vocal cord is like this. Maybe there's blood, maybe there's a tooth, maybe there's anything.
Qualsiasi cosa che
Oh, yeah,
Ok.
yeah.
Ok. Come fate a controllare le vie aeree una paziente di questo? Diventa veramente difficoltoso. Ok? Quindi dovete imparare a qualsiasi cosa nelle vie aeree, dovete essere pronti a fare qualsiasi cosa, anche nelle vie aeree difficili. Perché è fondamentale, soprattutto quando dice lui sentite rumori o respiratori o respiratori, quando ci sono queste compressioni delle vie aeree. Diventa un incidente, diventa prioritario questo punto controllarsi le vie aeree. Anche con il tubo accelerato rapido, sequenza rapida.
So stridor is very important if you hear any stridor, and especially if you hear expiratory stridor. Usually stridor is inhalation, but if you hear a sound with expiration, like something like that, be very worried. There's something obstructing the airway, and that's you need to address it first, right? Airway, then breathing. And so these are all the things you can do. We've talked a lot about this already. Jaw thrust, you know that. Cervical spine, giving oxygen, level of consciousness. If their GCS is less than 8, usually we would put in the breathing tube because they're too sleepy. Same as if they're losing their airway, they're starting to lose the airway, we intubate. If the oxygen is low or the PCO2 is high. And then these are some other sort of emergency things that you're not doing yet at your stage of training. I mean, you're not putting a needle in someone's cricothyroid cartilage. Not yet. Needle, yeah. Yeah. I mean, it's super advanced thing, putting a needle in and just doing like a jet of oxygen through a needle just to keep their oxygen level up. I mean, I guess I've only even seen it one time, but so now we talk about breathing. And again, we've already been through this, but it involves, you know, everything, rate, listening, touching, looking, observing. So we do all of that. And then we have a few procedures that maybe you should know to do in an emergency. This is one you do need to know. If it appears that someone has a tension pneumothorax, you really have to evacuate that pressure. And that's, remember, putting the large catheter needle in the second intercostal space. But you can also, my preference, and it's fine, you can also put it over on the side. Why do I like it here? The nipple is obvious. Everyone can see that. Come right over to the middle of the axilla, right there. Yeah. Nipple right over mid-axillary. And what's good is you put the needle in there, and if you hear air come out, then you have really done something great for the patient. And if you need then to put a chest tube there, this you can go the same spot. Now, if you think the patient has a tension pneumothorax, and it's, remember, tension pneumothorax is not just a breathing problem, it's also a circulation problem. Because there's so much tension, the return of blood to the heart is down, and you will see bad pulse, bad blood pressure. So it's really something you have to do. It's B and C at the same time. So if you think it looks like the patient has it, then you can put the needle in there. And if you're wrong, it's okay. If it looked important, you can just put the needle there and try it. Because I don't know where we have the picture. I have the picture right here. This is the big bad X-ray of tension pneumothorax. It has all the signs. This isn't just the lung, completely over distended with a pneumothorax. You can see the lung is actually curving all the way over into here. This is the heart is getting pushed all the way over. There's the trachea. This is the carina right here. The trachea is way over. So if you felt this patient's neck, I mean, the trachea is way over here. So this is and the diaphragm is flat. So this is everything with tension pneumo. But you should have already put the needle in this patient. To see this is like, whoa, we need to do this immediately. Put the needle in. Here's another interesting X-ray. Any ideas? Any ideas? Professor can ask you for your ideas in Italian. What do you speak? What do you see? See something here. See something here. Yeah, so even though there is a tube in the stomach. Before this tube was here, I've seen the stomach be so big it comes all the way down here. And then you're going to throw up, and also it's be very hard to ventilate. So you have to get that stomach decompressed. And this patient has a pneumothorax too. You saw it, right? So here's the lung. The lung is just this part, but this is all air. And it's looking like it's becoming under tension. There's a progression from pneumothorax to tension pneumothorax. And this one, I think, the heart is moving over here. And I think the trachea is moving to the left a little bit. So this may not be under a lot of pressure, but it's probably developing into a tension pneumothorax. Yeah. So circulation, the most important thing is getting vascular access quickly. That may mean just immediate interosseous. There was a question for me last time, can we have a regular IV? Well, you have to decide, how much emergency is it? If the patient is unconscious and they're bleeding, just get the interosseous immediately. If someone else can also get an IV, great. That's fine. It's not a law that you can't, but try to get this quickly, go to interosseous right away. You have to have the ability to access the vascular space and be able to give volume quickly. So a little tiny IV in somebody's thumb is not enough. You need a big IV or you need an interosseous. And it can be hard to do. I mean, putting a big IV, in a small baby is hard. So maybe you can't get it. So that's why we have to do this. And if we can't get it here, then we go here. And if we can't get it here, you can go distal femur, you can go radius, you can actually have a sternal. You can go, yeah, there's a good iliac crest. There's a lot of places. I thought actually, this saphenous vein, you're pointing to the ankle. Sometimes that's a good, there's this like the saphenous, remember the saphenous vein? Excuse me, but it's this one that comes here. Sometimes that's a good one that people forget about. And you can put an IV there. Yeah.
Questi sono i vari.
Yeah. And remember the saphenous vein. I mean, sometimes you can get it. Someone can try. Okay. So if someone is bleeding, then you need to give them back blood. Kind of makes sense, right? So you can give normal saline that's warm or lactated ringers initially, but if the reason you're in shock is because you're losing blood, you will have to give back blood. So usually packed red blood cells. And we can talk about this right now, maybe I'll go back to this just to say that when someone has hemorrhagic shock, this is TXA. It's an antifibrinolytic. So it helps your body maintain the clot. Remember, fibrin is in your clot. You know what I mean by clot, the blood clot? Fibrin is there. And we have naturally fibrinolytics, which break down the clot. So we want anti-fibrinolytic. We want the clot to stay. So sometimes we use tranexamic acid. This is TXA. Or if it's really bad bleeding, we can use this factor 7 product. This is concentrated factor 7.
Insieme a questo controllo la persona se c'è un trauma carico tempo massimo di sviluppare poco sparare lo spazio da quello che la persona deve fare quindi e animazione finanziata sono state per poi farlo che queste nuove.
Yeah. Okay, let's look at some of this. We've already discussed the assessment. This is what it is. Remember, one way we can tell about the circulation is to look at the mental status. If you're sleepy, that's probably because you're in shock and you don't have enough circulation to the brain. Although there's many reasons you can have altered sensorium, altered mental status. Maybe you have direct trauma to the head and you have cerebral edema. Maybe you've had ingestion of drug or alcohol, many reasons. And of course, always skin perfusion. It's an important one. We mentioned all of this: frequent assessment every 5 minutes at least, hemorrhage control, critical. Because if you don't control this, then the patient's going to die. I mean, if you can't stop the bleeding, they're going to die. Big IVs, sometimes above and below the diaphragm. But that was the old way to say, you like to have different IVs. If you have pressure in your belly, if I have a lot of abdominal pressure and my IV is in my leg, the medicine may not get back to my body, but basically get an IO, a good interosseous. And then bolus as you need, but remember, we're going to use packed red blood cells. This is to remind you of the normals for baby. These are the minimums. So this is really a circulatory failure if you're less than 60 or less than 70 up to a year. This is the little thing you remember, 2 times the age in years. So 4-year-old. So 4 times 2 is 8. Plus 70 is 78. And then here's when we're older than 10, up to being an adult. And you can see this everywhere. This is in PALS. It's everywhere. You don't necessarily have to memorize it. This is something that I got from the Royal College Hospital of Melbourne, Australia. And I'll give you the website address, the URL at the end of the talk. You can find this there. But it just gives you a nice review of really what we're trying to do. We mentioned tranexamic acid potentially, and then giving some warm saline. Is there still shock? Yes. Then we come down here. We talk about blood products. Again, if you don't have blood, you can give more saline, but you're going to need blood. Then you say, does the shock still persist? Yes. Now you start coming down here and it says packed cells or FFP. The point here is if you're bleeding out, you're not just bleeding out red blood cells, you're bleeding out serum, which is clotting factors, and platelets. So some places in the US now are using whole blood, fresh whole blood. That's kind of the ultimate. If I'm bleeding out fresh whole blood, can you give me some fresh whole blood? Thank you very much, right? But if you can only give me packed cells, then we take that and we do 1-to-1 packed cell volume and FFP, and then maybe 1-1-1, also platelets. So this gets into what you're talking about, the mass transfusion protocol.
Questo paziente vuoi iniziando per cominciare a fare subito per sangue. Posso fare 1, 2 sangue, non più. E dopodiché posso fare per attivare quello che si chiama protocollo. Se tornate a fare sangue, anche questo paziente per i giorni di fuori. Una sacca, 2 sacche per 3, dopodiché deve fare trasportare che sì, quindi il sangue, ma io lo do a pezzi. Mazze concentrate, plasma, yes. È possibile e questo è il punto per rompere la paura guardia. Non me lo porto alla nel frattempo cosa fa? Quindi va bene, ma subito sangue, ma subito di sangue. Protocollo per rilassare. Meglio come poi sì, a 10 e mezzo credo che fa come se non lo trovo. Però una volta così bisogna organizzare, bisogna mettere subito 5 ml di mazze concentrate, di aspirina, plasma presto, non fate questo al paziente, fate solo così, il paziente non vi causa quello che si chiama damage control, che non è il levare l'inizio, il fare la rapida, no, è quello proprio di fare un packing, quindi stivare, fermare dove c'è damage control, quando è tutto fermo, il paziente è stabile, poi fare la
Yeah. I mean, it's so important, especially if you're using, I'm understanding some of what, you're saying, the mass transfusion protocol, it's rapid infusion of blood. So it can't, did you mention that? Yeah. So you have to give the blood quickly. That's why you need a large IV. And sometimes someone will just give packed red blood cells with a regular pump over 1 hour. It's not good enough. If someone's in hemorrhagic shock, it's an emergency. You need to give it fast. Yeah, yeah. Yeah. Well, so if it's presumed hemorrhage, right? I mean, when someone has a trauma and they come in shock, we do presume, we assume, we make the consideration that it's hemorrhage. It's different than shock with vomiting or shock with, Yeah. Yeah. And so you don't have to start with normal saline, but it is included there because it's immediately available. Remember, you want enough volume in your body of blood volume, right? You want enough volume. I have 5 liters, you have 4.5, 4 liters, right? You want a blood volume, but you want the blood volume to be correct with red blood cells, platelets, etc. So but it's better to at least have volume than nothing. So if I lose 1 liter of blood, I'm in shock. Ideally, you would give me back 1 liter of blood, but at least give me a liter of something. Give me a liter of saline if that's all you have. You see what I'm saying? It's a complex point, maybe. You want to give packed red blood cells or other products for hemorrhagic shock, for sure. But you also need to just at least make sure you have enough volume for the pump, for the heart. So you can't get usually blood in 1 second or 1 minute. I don't know. I mean, you have to do maybe emergency blood. You can get normal saline or lactated ringers immediately. So you can give that to try to improve the shock and then come with the blood. Does that make sense? I mean, I suppose you could say, what if someone had some bleeding and it's controlled? And now they have shock, but their bleeding is controlled. Okay, you could just give, see what it says here? Consider resuscitating with blood products immediately. That's exactly what I'm saying. Consider blood products immediately. If not available, then sodium chloride, then normal saline. Yeah. Yes. Bleeding. Yeah. Yeah, infuse, yeah. For the blood. Yeah. Yes, that's why it says, consider resuscitating with blood immediately. Yeah.
Nell'attesa che per il scambio delle dopo del campionato vari affari la cosa principale che fare è sangue. Poi puoi fare sempre sangue e allora il sangue serve per campionare.
If it's hemorrhagic shock, use blood. You know, if you have blood, use blood. I guess the only thing, again, to keep in mind, I've had a patient I'm starting to lose their central pulse. You know, I cannot feel the distal pulse. It's gone. And I'm starting to lose this. I can just barely feel it. This patient is very close to arrest. And there's no blood. I mean, hurry up, bring me the blood, bring me the blood. While you're waiting, just give saline, okay? Because I'm just trying to keep the patient alive with some volume. I know I need blood. So don't, of course, don't let the patient die while you're waiting for blood. See what I'm saying? But if you're in a good spot, you can get blood right away. Mhm. Hmm. Oh, wow. An interesting question. Not cold. Not cold. Yeah.
Sono ipotermici per definizione, ma non solo perché sono studiati o perché sono fuori o perché quindi mai, ma per un motivo metabolico molto semplice, fisiologico molto semplice. Pazienti scioccati sono pazienti che sono in acidosi. Ok, e l'acidosi che tipo di metabolismo usa? Anaerobico. Lo sapete perché sono 37 gradi di temperatura. Dal lavoro dei domoti, che lavorano quando io devo scivolare tra la capacità energetica dell'aerobico è direttamente inferiore. Per cui se io sono in metabolismo aerobico, la mia temperatura automaticamente quindi guarda quindi come potete vedere al freddo poi e altre che integriamo noi
Yeah. This is also going to depend on where you are. If you're in a large city with a trauma, special resuscitation area for trauma, you will have a rapid infuser and you will have a blood warmer. So the blood runs through the warmer, immediately it's warmed up. Now, if you're in a small rural, small little health clinic in the country, you won't have a blood warmer necessarily. You know, I mean, I've seen some people even put the bag of blood, you know, under their arm. It sounds crazy, but you know, so, and keep in mind, if you're going to give me some blood and I'm a full size man and you give me a little blood that's a little bit cold, I'm probably okay. If you give a baby cold blood, they're going to be acidotic and, you know, yeah. Yeah. So you gotta, you gotta adjust your, what you're doing. So we'll go a little bit faster maybe, so we have time here, because we're gonna go till what, 4:15. So we only have 45 minutes basically. Yeah, we're okay, but I mean, I want to make sure we have time for this. This is good stuff too. So disability is when we are going to look for neurologic injury, neurologic signs. We do a focused exam, and then we're always suspicious of a problem with the head for children. The rapid assessment is something you would also know from PALS. This is helpful, AVPU. We can also use a Glasgow Coma scale for pediatrics, which I will show you. And then remember D also to help you remember dextrose, sugar. Because sometimes you'll have, I mean, the normal stress response to trauma is to raise your blood sugar. But sometimes when people are really critically ill, they don't have the normal stress response. And you would hate to miss that. So don't miss it. And sometimes it's a patient, you can't resuscitate them and you're like, what's the problem? And then you check the blood sugar. Ooh, it's low. So again, here's the assessments that we do, looking at pupil size, looking for extremity movement. You know, you can see, are they moving normally? Remember, sometimes if the patient's not moving their leg, it's because they have a fracture here, or they have pain, or they have a spinal cord injury. But if you pinch this and they move each leg, that's a good sign. So you're looking for these things. You're also looking for things like posturing. You remember like decorticate and decerebrate? You guys remember that from your medical school? Yeah. If you have an injury of the cortex in a patient's like this or like this, both are bad, right? But this is probably worse than this. Remember, corticate is like C, decorticate. These are interventions that you can do immediately if you see someone that has a sign of a neurologic injury, like a central nervous system. We want to, you know, obviously, if we can talk to neurosurgery, you know, keep the head of their bed elevated a little bit. But two points. If they are intubated, we do not want to hyperventilate. And we do not want to hypoventilate. We really want to try to have the end-tidal CO2 or the arterial CO2 be basically normal. Se dovesse, non deve essere impegnato, deve per fare il campo, aiutare, e guardare un tagliere, dare una tagliere, aumentare la presenza fino a 20 e 30 della vita. Normalmente, allora a quel punto sensibile che il range del Thailand di scitta da 30 a 35 e quindi avete una fotografia controllata. Quindi avete un'ipertensione da una lieve vasoconstrizione, ma di evita che non quindi è una manovra salvaguardia che chiaramente aumenta il danno cerebrale ma aiuta quindi poi vi ricordate che l'emografica lo dovete mantenere intorno ai 30-40. Questo lo potete fare o con un timer o con una ventilazione a questo. Okay, so the whole idea is if you have increased intracranial pressure, it's an emergency. And so the main reason to intubate is because they're going to lose the airway because if they're have so much brain injury. So we're not using the airway and breathing to control the intracranial pressure, but to maintain the airway. Sometimes in the ICU, we briefly hyperventilate a little, but that's a different consideration. Then we're balancing the risk and the benefit. If someone is about to die from cerebral herniation, maybe we hyperventilate briefly. But for this lecture in the trauma assessment, we main 35 to 40. Now, you would then be giving 3%, elevated saline or mannitol to try to decrease the volume of the brain, to try to decrease the pressure. So That's what we have here. This is the pediatric Glasgow coma scale. You can find it anywhere. I put it here because to remind you, for pediatrics, it's a little different than adults, but no need to memorize it. You can find it anywhere. And I don't have it memorized, and I don't think Davide has it memorized either. If you want to memorize it, be my guest, it's fine, but I try to save my brain. It's not so big. I need to save it for other things. This is what we're trying to make sure that we don't find for our patient. So you guys know which one this is? Epidural. Yeah, do we hear epidural? Yeah, because it looks like a lens. This is what we call lenticular in Latin, I think. Lenticular, it looks like a lens, and it's really compressing the brain, and it can cause this brain to herniate, and this can be fatal. You can see like the middle of the brain is shifted this way. The lateral ventricle should be here. It's not. Here's the lateral ventricle. This is completely, we call effaced. The lateral ventricle is squeezed. So this is an emergency if you see this. Whoa. You may also have some subdural blood right here too, I think, this little thing. But anyway, that's kind of an interesting scan. Exposure, got to undress the patient, and we got to look top to bottom. Remember, when we do that, our patients, especially pediatrics, have risk for hypothermia because they have a large body surface area and they can get environmentally hypothermic. Okay, what about x-rays? Initial x-ray, chest x-ray is in the initial evaluation. You can learn a lot of things from that. Pneumothorax, hemothorax, mediastinum. Pelvic x-ray is often done to look for bony abnormality, but these can be done with different protocols wherever you are working. In Italy, you're using a lot of trauma fast ultrasound. I think in emergency departments and for younger doctors, ultrasound is becoming very important. For, little bit older doctors, we don't do ultrasound maybe as much just because it's we didn't learn it when we were young. Like I know how to do ultrasound, but not like the super detail. Like you guys are good at seeing, and I think you probably use ultrasound a lot. Yeah. Oh, it's not a magic stick. No. Right. Magic wand, yeah. Yeah, right. Yeah.
La prima cosa importante è una clinica. Voi dovete far capire che sono il bambino dalla clinica.
Is the first thing. I mean, yeah.
La sonda mi serve solo per confermare lo smentire quello che non ti serve per
I mean, when I was your age, we used to do something called DPL, diagnostic peritoneal lavage. And you poke a needle right in the midline below the belly button, and you infuse saline into the patient's abdomen, and you kind of roll it around, and then you suck it out, and you see, is it red? Okay, he has bleeding there. Yeah. So echo, I mean, just to give you this history, and you can read about it, it's actually quite sensitive and sometimes can be more sensitive than ultrasound, I think, because ultrasound is only as good as the person who's doing it. Like if you give me ultrasound, I don't know, I can see something, I know how to do this, but DPL, you can really also look on the microscope how many red blood cells. If there's a little bit of bleeding, you can sense it with DPL. And then we take the patient to the abdominal CT scan, and we look at specific places like Morrison's pouch, which is this little area by the liver. Is there fluid in Morrison's pouch? So anyway, but yeah, so this is some of the assessment we do. You do ultrasound, that's cool. Cervical spine x-rays. Remember, the child has such a risk for cervical spine injury. And it can be not obvious because the ligaments in babies are very flexible. So you can have a terrible injury. And when they come to the evaluation, the cervical spine looks normal, but maybe the spinal cord can even be disrupted completely. Skiwara, yeah, skiwara. Spinal cord injury without radiographic abnormality. It's something you may like to read about. SCIWORA, skiwara. Spinal cord injury without radiographic abnormality. So, but we still often get what we call cervical spine views, because if you see the cervical spine is not normal, that's a problem. You don't come out of the collar. But when I was a fellow, here's a little story. When I was a fellow, we're just coming out with the airbag. So this was like 1996, 97. The airbags, right? There was a time when cars never had airbags. I know you know that. The old cars maybe just have no seatbelt. So it was not clear. People, now the cars, as you know, have a sensor in the passenger seat. If you sit in the passenger seat, it turns on the airbag. But if a child sits in the passenger seat, he doesn't weigh too much, the airbag is off. Have you seen that? There's a little light that says airbag off. So I took care of a patient when I was a fellow the toddler was riding in the mom's lap. Okay, it's not good, and then they got in a very minor accident, no big deal. No one's killed, maybe 20 miles per hour, boom, but the airbag went off. And the airbag went underneath the baby's chin and basically lifted his head off his body. And he looked perfect, no injuries, but he was in arrest and we could not resuscitate him, no matter how much volume we gave. And his spinal cord was completely disrupted. But his x-ray was completely normal. His cervical spine x-ray was completely normal. So that was one of the first, that was in the United States, and the federal government is observing highway accidents. And then they realized there were 2 other children that had this severe injury of basically, like they call it internal decapitation. Just pull the head off. Yeah. So anyway, it's just a story. Sometimes, the older doctors love to tell all the old stories, but sometimes the old stories are important to learn. So it was important to learn about the airbag, but it also showed me, you've heard of spinal shock. Maybe you've heard of spinal shock. I saw that is the most extreme version of spinal shock, where the entire spinal cord is cut. And you have complete loss of your tone of your blood vessels. So you can just pour in blood and volume and you can't resuscitate the patient. Usually, very hard to do. You've seen some bad spinal shock also. It's like it's a form of distributive shock because you have complete vasodilation. Yeah, warm shock. Completely. Yeah, it's terrible. So anyway, I saw that. So secondary survey, once you've done A, B, C, D, E, then we've addressed the immediate threat to the life. And then we have to go back and begin at the top, like you say, testa to the pie. Is that right? The feet, top to bottom. We're going to examine everything, and we're going to get a sample history. This is a little bit too large, but basically you're going to palpate and look at everything. Scalp. you know, behind the ear, do you have bruising? This is called battle sign if you have this. Palpate, you know, do you have an orbital fracture? Look at the pupils, nasal fracture, maxillary, you know, you're just looking for everything. We'll take another look at the teeth. Even though you've done the airway already, take a more detailed look. Feel the mandible. How's the neck? Is there crepitus? How's the chest? You already examined the chest, but you're going to do it again because now you may see something new. And the interesting thing about trauma is it's evolving always. Very commonly in the ICU, the next day, we find more injuries that we don't see in the emergency department. Because if this patient has a trauma, but he also has a fractured ankle, you probably don't see it. Even though you look, you can't find it. But the next day, I'm in the ICU, I say, wow, that's swollen and it's bruised. So this is your chance, go top to bottom. It's the secondary survey, feel the belly. Then we get to this point. Any injuries detected have to be noted and we have to prioritize the interventions. So in other words, now we have to say, okay, I've found everything that's injured. What am I gonna do first? Usually the bones come last. Sorry, this might just some texting coming in for me. People in the United States are waking up and asking me questions. It's like, go back to sleep. I'm in Italy. Okay, so then we do planning communication. We prioritize other tests, etc. I didn't include a slide of laboratory things. I did include a slide of potential secondary radiographic assessment. Just a few things to say. Anything that is injured here makes you think about the next test. So if there's a big bruise across their abdomen from the seatbelt, let's have an abdominal CT scan. If they have a potential, some finding on the chest x-ray, how about a chest CT scan? So that the primary and secondary assessment informs what you're going to look for next. Two key points. Number one, the C of ABC is not CT scan. It's not airway breathing CT scan. It's airway breathing circulation. And I've seen too often somebody quickly going to the CT scan because for the brain, and then they develop shock in the CT scanner. And that's like being on the other side of the moon. The CT scanner is not the emergency department. See. Yeah. Have cardiac arrest, have codes. Yeah.
Non ci devono andare se non sono stabilizzati. Allora sì, lo devo fare stabilizzati.
Yeah.
Se avete finito la pratica, il paziente è stabilizzato, soprattutto lo deve fare al secondo, se il paziente non è stabile, non fa
So you can't go to the CT scan until you're stable. Now, sometimes people are just barely stable. And when I was your age, I was the junior doctor on the trauma team. I personally would come to the CT scanner. And I can tell you many times in 3 years of this training in trauma, I would have to say, stop the scan, pull the patient out. He's going into shock again. The heart rate went from 90 to 140. Now I feel the belly, it's getting big. We have to go to the operating room. We can't get the CT scan. So just know CT scanner is kind of a dangerous time for the patient. So try to make sure they're stable. Having said that, it's a very, very helpful tool. You can see aortic injuries beautifully if you have that with contrast. It's perfect for liver and spleen, which are so common in children. You can diagnose that. But again, if you have a splenic fracture, they have grades 1 through 5, even grade 4, usually you're fine. The spleen looks terrible, but it clots. It's okay. But it's good for some of these things. And this is a little trick, but it's nice to look at the vena cava on the CAT scan, and then you can see how is the volume status. Because if I see the vena cava and it's flat, that means I probably need more intravascular volume. I like that little kind of a little trick. Okay, last thing I just have here about transport, because this is a lecture about trauma and transport. You know, transport is a whole nother area, and it really is very much dependent on where you go to work. So I can't say too many details about that, except to know you need to know what is your local resource. In other words, do you have an ambulance service? Okay, how much skill do they have? Do the ambulance service come with a doctor, or are you in the country? Should the patient go by helicopter? You know, you have to know your local area. But one thing, make a protocol as much as possible, because when you're transporting, you're kind of by yourself and you need to have protocols. And also make sure the communication is easy between the transporting team and the doctor at the hospital. Do you have more to say about transport? I mean, anything else you want to say about this?
Secondo il concetto di dipende dalla velocità, fase, la cosa fondamentale della fiducia naturalmente una rete perché in modo che quando tu hai liberato io parlo per il detto è stata fatta anche come combinato
I don't. Yeah. Receiving hospital. Yeah. It's so important. But again, it's a very different. In Italy, you have a doctor on the ambulance going to the scene of the accident. We don't ever have that in the United States. Never. There's basically no doctor that goes to the scene of an accident. It's all specialty nurses and others. So the doctor is waiting at the emergency department. We sometimes have the doctor go with an unstable patient from small hospital to big hospital. That's true. So because of that, what I do for transport is very different. Okay. It's too bad. Too bad to hear that. Thank you though. Okay, well, we can pick up the pace a little. We're basically done with the lecture part, but the point is for transport, you just get to know your local, where you're going to be working. So, you know, really, I don't have any more to add here. These are the references. I think these are 3 good ones for you. This Royal Children's Hospital of Melbourne is really a nice website. And they basically have like a manual for everything for pediatric trauma. It's nice. I would also say if you really like this, you should take the ATLS or the PHTLS course. We're telling you something in an hour or 2. ATLS course is 2 days maybe, or 1 or 2 days, I think. Yeah. So it's a great course if you're interested in this. And then I made these tiny URLs for you. This is something nice about anatomy and physiology of children. And here's how you do the trauma workup. You can email me, obviously, for any questions. It's my pleasure to talk to you about anything you like. And yeah, and now we're going to have like basically some demonstration. Or yeah. And you guys probably want to come in here up close so you can see. We're going to show you the stabilization.